My name is Dave Jerome. I'm an emergency doctor in Kamloops, British Columbia, and today I'm going to be talking about how to put on a tourniquet and how to assess tourniquets that have been put on by someone else and convert them to another form of hemorrhage control. So when you open up the tourniquet from the package, it's already going to be in a loop like this with the Velcro on itself. There's two ways that you can apply it. You can either make the loop bigger and then slide it onto the limb that you're going to be putting it on, or you can take the Velcro out completely, wrap it directly around the limb where you want to apply it, and then circle the tourniquet back. There's two areas that you can consider putting the tourniquet. Most people will put the tourniquet just proximal to the area that's bleeding, about 1 to 2 inches higher on an area that's going to be compressible. That means we don't want to put it over a joint, but we can put it anywhere on the forearm or on the proximal arm where there's tissues that are compressible. You may see a tourniquet that comes in from a pre-hospital environment where the provider has put the tourniquet on very proximally on the limb, and that's called a high and tight tourniquet. And they do that when they don't have time to really assess where the bleeding is. They just put a tourniquet on where they know it's going to work as proximally as possible. And those tourniquets can sometimes be converted or at least moved down closer to the area that's bleeding. Once the tourniquet is on the location that you want to put it, you have to pull it as tight as possible with the Velcro. And then every tourniquet needs to have a windlass to generate sufficient pressure to stop the bleeding. The windlass is the name of this hard bar that we're going to be turning around. Most people will need to turn the tourniquet windlass 3 times to stop the bleeding. And the last turn is going to need a lot of force. It's going to be uncomfortable for the patient. You're going to have to use 2 hands to get that last turn in, but that's the turn that's going to put us from a venous tourniquet to an arterial tourniquet where we actually have enough pressure that we're stopping arterial flow. Once we have enough pressure, which is confirmed by either loss of pulses distal or more importantly, the bleeding stops, you want to lock the windlass into place in the bar so that it maintains the pressure. And then you put the Velcro across and write the time that the tourniquet was applied. Multiple studies have shown that 3/4 of tourniquets that are applied can actually be safely taken off, and we can control bleeding through some other means, usually direct pressure or packing the wound tightly with gauze. This means that you should reassess and try to take off or convert every tourniquet that you see, either if it's a tourniquet you put on or you received that someone else put on. The goal is we want to try and get the tourniquet off in less than 2 hours. Lots of studies have shown that tourniquets that have been applied for 2 hours or less have no complications with them. Once we get above 2 hours though, we're starting to run into 2 different issues. The first is that we're causing ischemia and permanent damage to the tissues that are sequestered behind the tourniquet. The second issue is that ischemia is going to cause a reperfusion syndrome once we do take the tourniquet down, when those metabolic products go back towards the core. Reperfusion syndrome is a constellation of metabolic effects from taking off the tourniquet and having metabolic products go back towards the body. And the main elements include metabolic acidosis from lactic acid washout. There is a severe hyperkalemia because a bunch of potassium is being released by the cells that are ischemic. There is hypothermia because there's cold blood coming back towards the core. And then this limb continues to act as a heat sink. There can be cardiac arrhythmias that happen both because of the acidosis and the hyperkalemia. And so the things that we do to manage reperfusion syndrome, if we see it, is we try and alkalize the blood to deal with the acidosis. And we can do that by giving 1 amp of sodium bicarb 5 to 10 minutes before we plan to take the tourniquet down. The second thing we do is we want to protect the heart against that acidosis and the big bolus of potassium it's going to get. And so we do that by giving an amp of calcium gluconate about 2 to 3 minutes before the tourniquet's coming down. If you have the ability to measure potassium levels in your patient, you want to bring the potassium levels to low normal range, around 3.5 millimoles a liter, so that when the potassium goes up, it has runway and we can increase the potassium without putting them into a dangerous range. And so we want the serum potassium level to be lowered down to about 3.5 using insulin and dextrose. The final thing we can do is we can try and warm up the limb before taking the tourniquet down with warm towels or blankets, etc., so that this limb and the fluid in it isn't as cold when we take the tourniquet down. So above 2 hours, we're worried that we're causing damage, and we're going to have to manage reperfusion syndrome when we take the tourniquet off. It's still reasonable to try and take the tourniquet off as quickly as we can within the 2 to 6 hour time frame from when it was first applied. If the tourniquet's been on for more than 6 hours though, there's limited benefit to taking it off because there's already been permanent damage to those tissues, but there's significant risk because there's a very high risk of reperfusion syndrome. So if a tourniquet's been on for more than 6 hours, you should not try and take that one off, at least until you've talked to a higher level of care. If you're thinking about taking a tourniquet off, there are 3 specific contraindications to taking off a tourniquet that you need to consider. The first contraindication is if your patient is actively in shock, do not take off the tourniquet, because taking off the tourniquet can potentially make them sicker, so we don't want to take people who are already unstable and make them more unstable. Resuscitate them first and then see if you can take the tourniquet off. The second contraindication is if you're not going to be able to monitor the patient after the intervention, then don't do the intervention. This often comes up in the context of patient transport. If they're about to go into a helicopter or another platform where people will not be able to access the area that's injured to reassess it or reapply a tourniquet if required, then you should not take the tourniquet off before making that move. The third contraindication to taking off a tourniquet is if the limb's been amputated. Because there's essentially no value to taking off the tourniquet, we're not worried about salvaging the limb if it's already been removed from the body, but there's potential risk, and so those tourniquets should be left on as well. And there you have it. That is how you put on a tourniquet and how you assess and hopefully convert a tourniquet that's been put on earlier.